But firstly, I'd like to acknowledge the Tasmanian Aboriginals as the traditional owners on the land on which we meet today. I'm here in Muanina lands, and I'd like to pay my respect to elders past. I'd also like to acknowledge any individuals with lived or living experience of drug or alcohol use and treatment, and those people here today who strive to improve the lives and well-being of those who experience drug and alcohol dependency, their families, loved ones, and the carers as well, if there's any carers in the room. Jackie, over to you.
Thanks. Thank you, Dan. I'm very, very pleased to have Associate Professor Raimondo Bruno here today to present the very latest report on our workforce. We've been doing this every two to 3 years for a considerable period of time. And this represents, is it the 7th, 8th, or 8th, something like that. It's in the report. And it's a really great, important and central piece of work. Every peak around the country runs, or pretty much nearly every peak anyway, around the country runs a very similar survey with the intent of providing a profile of our workforce and then identifying sort of emerging changes, issues and needs. Sometimes I feel like I'm stating the obvious when I provide this sort of overview, but not everybody is aware that there's about to be a workforce strategy which is going to be in development in the next financial year, and that's through the AOD reform agenda work, of which this information will be central. There's the work occurring at TASCOS across the broader community sector, and this work will also allow us and support our voice to advocate for the AOD workforce within those broader processes. And again, there's a wider health workforce piece of work as well through the Department of Health. So there's several intersecting ways that this information about us is going to be extremely useful moving forward to make sure that we've got visibility, a voice and so on when we contribute to these processes. And the other really important aspect to this work is that we'll support our budget bids. The workforce is central to everything, obviously, that we do. We're a values-based workforce, and so investment in our workforce is really the aspect which is going to drive down drug and alcohol, or alcohol and other drug-related harm. Anyway, that's enough motherhood statements. That's enough stating the obvious from me. Thanks very much. Am I passing the baton to...
Back to me.
Back to you.
I just want to introduce, because I forget that there are people on the chat today who may not have encountered Bruno before. For the past Associate Professor Raimondo Bruno, for the past 2 decades been conducting research relating to substance use, and is the lead researcher on Drug Trends Project for Tasmania, which is an internationally renowned system that NDARC has coordinated since '96. Which talks about drug trends across Australia. But if you go to a conference or you go to a committee or at a prompt response network and you work in policy space, etc., that you're going to encounter Associate Professor Bruno. So we've set Bruno a bit of a task to cover such an enormous piece of work. When I share the report, which I'll do at the end, it's amazing. Like, it really is an extraordinary piece of work. I'm not just saying that, it's quite amazing and very exciting to share it. It's bigger and better than I think we've ever seen before. If you have any burning questions, feel free to pop them in the chat. Bruno's cool if you put your hand up or interrupt as well, but there's a lot to get through. So yeah, in the first instance, hit the chat, and Bruno, over to you. Thank you.
All right. Welcome, everybody. I want to give you an overview of the sorts of things that we've come across through doing this report. It's going to be a very simple summary of the trends, because there's lots of moving parts, and I've tried to put it together in themes to help identify any emergent issues. I guess the punchlines are that the workforce that took part in this seems to be pretty comparable with the workforce that we see nationally, those trends. And the workforce is largely happy and healthy. There are a number of vulnerabilities that we can see through looking through the data. And I'll try and emphasize those as we work our way through. So please, I've got in front of me many monitors, and there's a detailed spreadsheet on many monitors. So if you've got a question, I can, just shout at me, and we'll have a discussion. It'd also be really useful just to see whether people think that this is matching their experience, or if there's we've missed the mark. Dan, the recording seems to be fine. Okay, so just to situate this, it's important to note this is a convenience sample, so it's only people that were interested in taking part. And usually that means that you get the people who really love everything and the people who really hate everything, and the middle third may not respond. But that said, we're not exactly sure about the size of the workforce, but there does seem to be a pretty good coverage. The sample size there's two surveys here. There's one of organisations and one, so where a manager took part to talk about the bigger picture that they're seeing and identifying the threats and challenges as they see it. And as well, we have a survey for individuals who are part of the workforce. The sample size for that was relatively large as far as this study goes, so that's a pretty good coverage. If anything, looking at the workforce, there's possibly a little bit of an overrepresentation of people from the Northwest, which is great. And perhaps it's hard to tell whether there is an underrepresentation. I know that the number of services in the North could be larger. One thing to note too in this survey, unlike the last couple of surveys, there was a pretty good presence from government staff as well. So about 10% of the workforce survey were from people involved in the government agencies. Other things that I want to mention is that throughout this, what I've tried to do is to have some comparative data. And the things that we're comparing to is primarily the national picture from the NCETA workforce survey that was commissioned before the plague. And that was a pretty big sample size of 1,500 workers across Australia. That study only had about 20 workers from Tasmania, so there's not a huge amount of overlap, but it's great to put this stuff into context. We've also did a lot of work in trying to pull questions from a lot of the other peak agencies. And I'm very grateful to have worked with a group of people with lived experience to workshop some new questions about the lived experience workforce and their experiences in doing the work that they're doing. Okay, so we've got a rapid bunch of slides. There's a consistent color theme. I'm colorblind, but people tell me this is orange. Maybe it's red. That color will uniformly be the 2023 data. That blue is going to be what we saw in comparative questions nationally. And in general, so we'll whiz through these things, but to orient you, there'll always be something on the side to see what we're talking about. Workforce, I'm not going to surprise anybody by saying it's predominantly female. That's pretty much comparable to the situation we have nationally. If we look at the age distribution, as a stats nerd, that's a beautiful bell distribution. But what we do see, though, is that we see about a third of the workforce over 50, which is relatively comparable with what we see nationally. But there is a little bit, the majority of the workforce is in that middle age bracket. Now, this is something that it's worth coming back to when we look at how many years of experience the workforce have in the sector, because the majority of the workforce have been there for 0 to 5 years. There are looking at some key demographic groups. We see, there's about 10%, give or take, of the workforce that are from an Aboriginal Torres Strait Islander background, about 15% from an LGBTIQA plus background, and about 10% identify as having a disability. That disability group is trending upwards, possibly, as I have a feeling that is as we broaden what we perceive as a disability, rather than not just being visible disabilities, but invisible disabilities and mental health conditions. One of the other useful things is to ask people about, how, in terms of, it's great to have a diverse workforce, but you want people to feel comfortable in their diversity. And the majority of people that we spoke to agreed that they were very able to be themselves. However, that seemed to be lower in the groups that are, part of the LGBTIQ community, or the disabled community and a cold community. So there's lots of it. Things seem to be going better for the Aboriginal Torres Strait Islander workforce, but I think there's some important recognitions of these other groups as well. When we were planning this, we looked at a lot of the local policy documents about what the priority demographic groups are for drug and alcohol related services. And we asked people about, for those that were having client contacts, and there's about 25% of the workforce that took part in the survey didn't have direct client contact. They were in associated roles. But amongst the people that did have client contact, we talked about, okay, these are the priority groups. How often are you working with these groups? And we can see that the majority of time is spent with adults. There's a lot of engagement with females. Males, not a priority group in particular. There's a lot of engagement with people that are at risk of homelessness or homeless, and a lot of time spent with people with co-occurring conditions. All of the priority groups are visible amongst the sorts of clients that people are working with, but there are some notable areas where there seem to be less engagement with, and that reflects where the services are oriented to, particularly around children and young people and children of people who use substances. And that's notable given that, it was very common to see people working with clients with children. So that may be an area of interest. And similarly, there was lower levels of engagement with refugees, which may reflect, what's going on in the Tasmanian community. Moving on to training. I'm sure you've all been reading the horror stories in the Mercury about the general indicators around education in Tasmania. But about 2/3 of the workers that we spoke with had an undergraduate degree or higher. That's a little bit lower than the trend that we see nationally. And it's pretty similar for those that were in client-facing roles and the overall sample. Now, when we dig into that a little bit more, one of the, I think, the bigger ticket points of discussion that come out of this is looking at the proportion of the workforce, and this is the people in client-facing roles that have specific qualifications that are related to alcohol and other drugs, which was 27% in the Tasmanian sample in comparison to 71% nationally. Now, there are 2 jurisdictions in Australia, Victoria and the ACT, that have minimum standards for their workforce, and there's a lot of support for the workforce to achieve those minimum standards. And in Victoria, at least, the minimum standard, even if you have a tertiary qualification, then you're still asked to complete the AOD skill set. ACT also require that client-facing staff have a first aid certificate as well. So that's a big disparity. That doesn't mean that our workforce isn't doing great things. It means that they haven't had access to these particular parts of training. If we look at the completion of the vocational AOD components, it's pretty much matching what we were seeing in comparison to those national figures. It's about 20 to 25% have done those core AOD skill set units. There's pretty good engagement with first aid, which is fabulous, but this is one of the few real differences between the workforces. Now, despite that, staff were pretty uniformly confident in their ability to do the work and to respond to the needs of clients. And it's important to acknowledge that just having the tick of a vocational degree doesn't make you, by definition, a better worker. And but it's good to point out that staff are pretty comfortable in their skills. One thing that we did to follow this up is that the Victorian workforce and the Victorian peak have started to specify some core competencies that you can assess the workforce on. And as part of developing that, VADA started to get, in their 2023 survey, started to get their workforce's views on how confident they are that they meet these particular competencies. And we thought it was a little bit risky to ask the workforce these questions because it was a bundle of 50 questions in the middle of an already long survey. So I was pretty pleased that we got over 100 respondents to these. These are all people in client-facing roles. And this sort of covers the core themes that the competencies are all about. And in the main, just to summarize this down, the workforce were all pretty, they either agreed or strongly disagreed, 75% or more, that they met all of these competencies with a small number of exceptions. The main ones were being confident around what's going on with medications for AOD related conditions and mental health conditions, understanding classification systems, understanding how to assess for mental health problems and whether clients are experiencing family violence. That's a particular quirk of the Victorian system where there's a lot of emphasis on being able to identify risk of family violence across multiple service providers. So there's a lot of training emphasis on that. There were some gaps in people's ability to work with family members and carers as part of the work that they do. That's notable because about a decade ago, there was a very large amount of work on family sensitive practice. And that seems to have, it could expand again. And there were some benefits that people saw in being able to get, some limits that people perceived in their abilities to work in partnership with local Aboriginal Torres Strait Islander groups, with people with lived and living experience, and using interpreters and other supports. Moving beyond formal qualifications, we all know the importance of ongoing professional development, particularly when you're dealing with a complex client base and wanting to maintain best practices. This was another notable point of difference in that only 3/4, or you could say 3/4 of the workforce did engage in professional development in the last year. This was substantially lower across all levels in terms of short courses, brief training, or conferences. This was much lower than what we could see in the national trends. There are a lot of benefits with living on a small island. Quality of life, we don't need to drive as much, but access to these sorts of professional development experience is a lot tougher, particularly as we go outside of Hobart. So this is always going to be a bit of a gap, but it was something that came up quite a lot in the qualitative feedback. A lot of the staff really noted that they felt a real decline in what was available to them in terms of professional development. The managers noted this, and there was a group of questions on how organisations have responded to funding challenges, and about half of the managers we spoke to had said, look, in order to maintain the service that we're having, we've had to make cuts, and we've had to make some cuts in professional development budgets. So I think that's another area of note. In terms of clinical supervision, to support staff in their clinical roles, it's interesting to be able to cross-tabulate across the survey without making assumptions on what staff do based on what box they tick about what their role is. So we asked people about, were they actually working directly with clients? And then also, were they engaging in clinical supervision, and did they see that as relevant to their role? And only 80% of the people that were directly working with clients felt that clinical supervision was relevant to their role. Many may argue with that particular view, but of the people that felt it was relevant, most had access to it, felt that it was beneficial, and that they accessed it regularly. One thing that is notable, again, particularly because we are a very distributed state, it's difficult to access good clinical supervisors is that the majority of the clinical supervision that people did get was at an individual level. Whereas if you look at what's happening at the workforce nationally, there was more of a use of group-based clinical supervision. And given that if you talk to managers, they're pretty happy with the clinical supervisors that they can access, although there are issues around affordability and whether they directly have knowledge about AOD issues, potentially engaging in more group level supervisions may be a way of balancing out some of the financial pressures and being able to support more staff. Okay, there was a bunch of questions about the lived experience workforce, which was new to this survey, and we, as I noted earlier, we worked with a great group of people with lived experience to try and identify questions that matched the sorts of things that mattered to them and their experiences in engaging in the Tasmanian system. And also we pulled a bunch of questions from existing work nationally. Now, about 2 and 3 workers note that they had had some lived experience of alcohol and other drug use. It's about a third, though, that are happy to say that that personal experience is their lived experience. It's more common that people report family members or close friends being their source of lived experience. These rates are pretty similar to what we see nationally in terms of personal experience and the overall rate of lived experience. About 3 and 5 that had some lived experience had disclosed their lived experience. And so of the 2 in 5 that didn't disclose, mainly people didn't really feel it was relevant to their work. And it was notable that there were lower rates of people saying, look, I didn't disclose for reasons associated with stigma in comparison to the national trend. So, you know, confidentiality of privacy and to avoid stereotyping. I think that is part of a broader trend in the sector for people being more comfortable to be open about their lived experience and feel that that will be supported, remembering that this national survey was done in what seems a lifetime ago before COVID hit. We also looked at why people disclosed, and there was a very strong component around, you know, to challenge stigma, to support the visibility and experience and voice of people with lived experience, and to support clients. So these are all fabulous outcomes. One thing that we did, and this is a really complicated slide, but a lot of people said that they had some lived experience, but a proportion, 20 odd people, said that they had actually been employed in a lived experience role in the last year. So we asked them about, okay, what sort of tasks did you engage in to cover the breadth of things that people with lived experience are employed in? And then when you did it, tell us a little bit about, did you feel that this was something that was beneficial to you, or was it the exact opposite? Did you feel that your work was valued by the people that engaged it? And then we also asked matched questions to the managers about, had they engaged people with to do these roles? Did they find that valuable? And do you have plans to continue to do that sort of thing? And in the main, the story was great in that the people that had been engaged in these roles, and we're not just talking about working directly as a peer worker, we're talking about co-design, being part of forums, providing training and the like. In the main, people's experience was quite positive, and that people felt that it was valued. And certainly the responses from the managers were that they noted that this was a valuable thing for the way that they designed their services or worked. And so much so, we're going to put our money where our mouth is and continue to do it. So that's a great story. There were some areas where a little bit more attention might be needed in terms of there was still a positive, but a slightly less positive experience around directly working as a peer worker. And some of those challenges are ones that it's going to take a lot of time and energy to work through in terms of training up the other drug and alcohol staff to work out how to engage with lived experience peer workers and how peer workers interact with people that they might also know in a different role. So that is something that the sector is going to have to come to over time and establish some norms. There were also some issues around, well, some of the areas where there could have been better experiences was in terms of providing policy review and providing training. Often people with lived experience talked about, we were kind of thrown in the deep end, and if we were providing training, it might have been nice to know, to get some training in how I should be providing training rather than just go, oh, you've got lived experience, you can go and tell people stuff. Similarly, with getting people involved in selection panels, some supports with people making appointments and getting times right and those sorts of things were identified as potential issues. But in general, all of the experiences were pretty positive. They felt that NGOs having a voice was good. There's an emphasis on the importance of NGO sectors. There was, managers could really see that lived experience advocates were able to get messages across more potently sometimes than other groups, and the like. We often have a bunch of questions about, for people with lived experience, are there some very practical barriers that can get in the way of them engaging with this sort of work? And a lot of the things that you might be, that come up in the literature a lot is, perhaps do basic things like numeracy and literacy and access to the IT that you need. That seemed to not really be too much of a barrier. Some of the things that were bigger barriers were issues around concerns about stigma, concerns about, issues with people managing their own mental health as well. There were a little bit of things that came up in the qualitative feedback in terms of having, sometimes the restrictions around their treatment would get in their way of ability to engage with the services in the way that they would like to as a worker. And also tricks around legal history and being able to get working with vulnerable people checks and ticking off other sort of policy things for the service that could get in the way a little bit. There were some indications, though, that the people that were employed probably felt that they would have liked a little bit more recognition for what they bring to the role. People kind of had noted that there had been some discrimination towards other services users that the service that they work with supported. But on the positive side, it was pretty uncommon for people to feel that they were treated like a second-class citizen in comparison to the other staff, which was great. if we talk to the managers, a theme that came up was that the managers that responded to the survey that had done the work in terms of integrating the voice of people with lived experience into their agency found it valuable, and had seen a lot of tangible benefits from it. We talked a little bit about, in the survey for the managers, in this top portion, it's for people's plans. So we talked about, do you have plans to engage with lived experience advocates to help you with policy and training and those sorts of things? But then the other question is, that's nice, but are you also planning on paying people, which is an important part of the role? So in the top corner, we're talking about the management plans for reimbursing lived experience advocates. And in the bottom corner, we're talking about reimbursing peer workers. So there was pretty high levels of plans for continuing to engage with lived experience advocates, but this was pretty vulnerable to funding availability. And it was pretty clear that there is a willingness to get peer workers to do direct client work, but a lot of that is contingent on the availability of funding to do so and the continuing of that. So I think that is a real theme that came through. A lot of people are finding value in this, but it's increasingly vulnerable in a tight funding environment. And if it's something that the sector wants, then it might need to be built more into contracts rather than being something that could be seen as something that would be nice to do rather than core business. I won't belabor the point. I've covered most of this, but managers were pretty happy with the lived experience workforce that they had. But in terms of barriers, I thought this was pretty notable, that there has been a significant investment in time and effort by the community sector to support and grow lived experience advocates and peers, but then they get poached by the government sector for higher money, which there's a few smiles in the local environment. Yes, good. All right. We asked a series of questions around stigma. We took this from the Zest consultant group, who'd done a lot of work with New South Wales Health. And it's tricky to get at stigma without being leading and saying, look, you know the right answer you should give, and letting people actually not have the sort of most socially appropriate answers. One thing that was worth noting is that people were pretty positive in saying that it was not that common for them to see stigmatizing responses to people that use drugs by other people within the AOD field. But there's work still to be done in terms of the way that people outside of the AOD field respond to people that use substances. In general, the workers had pretty positive attitudes towards engaging with clients and felt that it was really important for them to reflect on their own behaviours and hold the other workers in their organisation accountable. This question here about whether you would advise close friends not to tell anybody about being treated for AOD issues is kind of an internalized stigma, and thankfully that was surprisingly low. This is also getting at how people perceive and the experiences people have when you're working with clients. And we do a lot of saying about, the clients are, you've got it's a challenging client group and it's a difficult job. But when you actually look at the experiences of workers, the darker the blues get in these plots, the more often these experiences happen. And people were, in the main, the workers were saying, look, a lot of the time, often or always, we see people acting as active participants. They're grateful for the help. And while people may not always follow through on their agreed treatment plan, I know that I don't always, or I never follow through on my agreed treatment plan for my own health. And the experience, so the majority of responses were in the rarely or only sometimes for the experience of verbal abuse towards you, or concerns that a person may be unpredictable, or that you're going to come out of your interactions with clients feeling bad. So they were much less common. So in the main, people the workforce were saying that they're having more positive experiences with a client group than negative ones. And that's an important component for maintaining non-stigmatizing views towards the people that you're working with. Now, in terms of employment, this is something that was also notable. If you look at the years of experience in the sector, only about a quarter of the people we spoke with had been in the sector for 10 plus years. That's almost half the rate of what you see nationally. And the vast majority of people have been in the workforce for 5 years or less. And that's a little bit higher than what we see nationally. So I guess that validates the sorts of things that managers are talking about in terms of the difficulty of retaining staff into the sector in the long term and losing that knowledge and experience that you get. It was really great to see that the majority of the workforce, 3 and 4, have got permanent contracts, and that situation seems to have remained relatively stable since the last survey. About half were employed full time. That's a little bit less than what we saw nationally. And thankfully, if we asked the workers what they planned over the next couple of years, about 3/4 said, look, I may not stay with the same employer, but I'm pretty likely to continue to be doing AOD work of some description. There is about 10% or so that are likely to be moving pretty soon. This matches pretty well with when we spoke to managers about whether they found it difficult to retain staff or to recruit new staff. We found that managers, if they looked at how many roles they had for drug and alcohol roles, how many spaces, that about 10% of the roles were vacant at the time of filling the survey. They'd needed to fill about 10% in the past year, and they're anticipating about a 20% turnover, which fits pretty nicely with the sorts of things that the staff were telling us. There were questions about, if you could have as much funding as you like, how many more staff would you want to actually be able to meet demand? And when I looked at that, I thought, people are just going to come up with insane answers, but they were actually pretty reasonable. And they're saying, look, if we could increase by 80%, then we'd be able to meet the role. So that certainly tells you that there is a gap between what agencies are currently doing and what they perceive they could be doing to meet the potential demand. And we talked about issues with the managers, issues around the challenges from gaps between funding levels and cost indexations and the need for real-time increases in salaries as people become more experienced in the role, and it is having a significant impact on how agencies perceive the long-term viability of their service and their ability to plan strategically. And it is having some clear impacts. We asked managers, okay, what actual behaviours did you need to change in response to these funding gaps? And there were cuts in staff hours. People were maintaining people in vacancy control, and about half of managers were also talking about finding cuts outside of direct service delivery to maintain the viability of their services. So I think that was another issue of significant interest. Looked at drivers in and drivers out of the sector. Notably, low pay was not a thing that people thought was a key reason why people left the alcohol and drug sector. People were asked, okay, tell us your top 3 reasons why you think people may leave. And the majority of it were the stress from the job, the nature of complex clients, and a demanding workload. Interestingly, workload came up not as much in the national survey, and the key issues were about the employment benefits nationally. So that was a difference for the Tasmanian groups. In terms of negative experiences, we pay a lot of attention to the experience of things like, intimidation or negative interactions from clients, and about a third of the people we spoke with had that sort of negative interaction occasionally, but there was also a bunch of people that had experienced these sorts of things in their roles with other members of the workforce and management. So that's an issue that requires as much attention as we do around working with the clients. Burnout, though, rates were equivalent to the sorts of things we're seeing at a national level. There's about a 10% turnover of staff. There's about a 10% of staff that feel burnt out. That's not going to be a perfect match, but they're about the proportions that they're dealing with. On the positive side, though, the majority of the workforce felt that, when they were going through difficult situations, they did get good support from their management and team members. When we look at what attracts people into the sector, the main motivation, and I think Jackie was saying we're a values-based workforce, that's the sorts of reasons that people talked about why they wanted to work in drug and alcohol, to be able to help people that were going through tough situations. It's interesting and challenging work, and that they had some sort of life experience or the relevant skills for the job. It's much less about careerism and more about directly being helpful. And the majority of staff were feeling very positive. Almost everybody was satisfied or very satisfied by their job. They felt respected at work. They felt that the work that they were doing was really meaningful to them, and that their quality of life was doing well. So these are all great indicators about the sort of well-being of the workforce. And lastly, and I'll just leave this up there as we turn to any questions, we asked some qualitative questions around from the workers. We said, okay, what does your agency need to do more of or stop doing to help you flourish in your role? and there were direct call outs for maybe we need less mandatory training around hand washing every year and to improve some of the policies and procedures to streamline things, more transparent management, more opportunities for professional development. And managers were asked, okay, what do you see the biggest challenges for the sector? And, you know, there's those key issues around sustainability, maintaining staff, keeping them well supported, and having the time to think about innovative services, developing more strategic plans, those sorts of issues. So I'll stop there and open up for any questions or discussion.
I'm welcoming any questions through the chat, or even for that brave person who wants to put one through the microphone.
I've got one if no one else does.
Go for it, Jackie.
Okay. Bruno, your view as an academic in the tertiary side of the sector, going back to the AOD specific qualifications,
Yep.
and noting us as a island state, although a lot of education and qualification can be, provided online and so on these days. Noting the ATDC has in the past attempted that minimum qual approach and did look at the skill sets. In doing so, they had this, we had this approach whereby the AOD skill sets were relevant for a part of the workforce, and then another part of the workforce, the idea was that they may well source more specialist AOD qualifications at a tertiary level, because they do actually exist, whether it be in nursing or in pharmacotherapy or whatever whichever part of the workforce it's coming at, they do actually exist. Do you have a view about our sector? And I guess one of the aspects of our sector is that we are a comparatively small sector, perhaps with less options within Tasmania, but again, it doesn't have to be within, it can be online. Do you have a view about AOD specific qualifications, and what could be what could fit our sector?
Look, I think as we're increasingly working towards best practice engagement, better interactions across the range of sectors, the sorts of things we want to see in the reform agenda in terms of having less silos between, oh, this is a mental health issue versus this is a drug and alcohol issue. I think the evidence is pretty good for the needs to have an upskilled professional workforce. I do like the approaches taken in the ACT and Victoria. ACT is, not particularly different to Tasmania in terms of the size, but there has been a lot of, funding support to actually get that workforce skill set up. I think it will also have benefits in terms of long-term retention of staff, because you will get more people that feel that, I'm part of a skilled alcohol and drug workforce. And so we'll continue to seek jobs in that area as they become more professional and specialised.
Okay, thanks.
We've probably got time for one more question before we wrap it up. So this is your last chance. And if not, I'd just like to say thank you to everyone for joining this this presentation. We've got a very diverse, high-performing workforce. They're very engaged, as we've seen by the stats. That's very exciting. And I'm really appreciative of the member organisations that also contributed. I can see that there is a question there now around the lived experience mandatory component. Bruno, if you wanted to answer that one before we wrap it up.
Look, I think all of the key strategic documents are talking more about recognizing lived experience as part of the workforce and the importance that that can bring into the sector.
And I think there's plenty of detail as well in the workforce survey report, which I've literally just put in the chat for you to have a look at. You can download that and find some more detail. The devil's in the detail, as they say. Bruno, thank you so much for presenting today on this fantastic piece of work. You can reach out to myself or Jackie if you've got questions about the report. You want to follow up on some questions in there. And with 2 minutes to go, Jackie, did you have anything you wanted to say, or Bruno?
I'll chuck a couple of motherhood statements in. I think the strength of this work is the nuance. I think on one hand it is great to see the inherent strength of our workforce. And so there's the capacity to build on that strength. But at the same time, it is heartbreaking at times, and the lived experience side of things with the funding fragility there, you can kind of see how quickly all of the investment and time thus far could be lost. I don't think it will be, but I think this work sort of highlights and shows that, and that's extremely important moving forward.
Great. Thanks, Jackie. Thank you, everybody. Have a wonderful day, and we'll see you again down the screen soon, I'm sure. See you all.
Thank you all. Bye.